Wong Rieger, and I am President and CEO of the Canadian Organization for Rare Disorders. Thank you very much for being here, and thank you for the opportunity to speak. As you know, we call them rare disorders, but frankly, individually, yes, they're rare, but collectively, because there are thousands of them, altogether, they're not rare at all. About 1 in 12 Canadians has a rare disorder, which adds up to about 3.5 million Canadians. 2/3 of those diagnosed are children, meaning there are several million other Canadians who are parents of a child with a rare disorder, and additionally, millions more family members. Increasingly, also, rare disorders affect adults. So rare disorders are not really rare. They impact a large portion of Canadians. And that's why Canada's National Strategy for Drugs for Rare Diseases is so really important. It's been helping Canadians, providing up to $1.5 billion in funding to national programs, as well as provincial and territorial drug programs. So we're now just about the halfway point of that strategy, the first 3 years of funding, from April 24th to March 2027. And thanks to the bilateral agreement between the federal government and every province and territory, many Canadians now have access to 9 important treatments for some very serious rare disorders, as is detailed in our press release. And for us, this is really great progress. Health Canada is providing strong leadership for the strategy, and I'm pleased to have been part of the implementation advisory group, an indication of the important contribution of stakeholders to the rollout. But I think, as we know, a whole lot more needs to be done. Many of the patients do not benefit from the treatment, even though these treatments are funded. They're in the provincial and territorial plans, because frankly, they just are not diagnosed. They don't get diagnosed in time, and quite frankly, by the time they get diagnosed, many of them will have been very severely impacted by the disease. The terms of the national strategy do call for provinces and territories to screen and diagnose, but frankly, most of those initiatives have not been implemented. So CORD, on behalf of our patient community, along with the healthcare community, is committed to working with the provinces and territories toward timely diagnosis and treatment access, as well as data collection programs to capture real-world use and outcomes. This will let us assure that those patients who are on therapies are actually getting the benefits that were intended, and quite frankly, that we can collect information to show that there's an economic and societal return on that investment. CORD's recent national survey, which was conducted by Ipsos, found that living with a rare disorder imposes a disproportionate toll on parents, patients, and families in comparison to those without a rare condition. Our families spend thousands annually on out-of-pocket medical services and prescription drugs, and over 1/3 require more than 4 hours of unpaid caregiver time every day. Underscoring the challenge of diagnosis, more than 2 out of 5 patients report that they have been misdiagnosed before they got an accurate diagnosis. And on average, it took about 7 visits to a family physician, 7 visits to medical specialists before they got an accurate diagnosis. We can do a whole lot better. A recent U.S. survey found that earlier diagnosis and treatment reduce long-term costs for both families and the health system. So the earlier you can get diagnosed and get access to treatment, the better, obviously, for the patients and the families, but also it has a real impact in terms of savings to the health system. And those were the same findings that were in a European study that was done recently. So earlier access to treatment for rare diseases reduce the overall burden. I mean, that's why we're working here as CORD, patients and healthcare community, to ensure that the second half of our first 3-year plan is going to focus on improvements in screening and diagnosis. We're also all here to start planning for phase 2 of the strategy beyond 2027. We want to ensure that the federal government continues to direct funding for drugs for rare diseases, as well as create comprehensive coordinated care models to make a real difference for patients. I think we would all agree that caring for Canadians is not just a 3-year project. It must be a key part of our healthcare system for many years into the future for the benefit of all Canadians. We at CORD are ready to work with the federal and provincial and territorial governments to make that happen.
Merci beaucoup, Durham. Thank you so much, Durhan. And good morning, everybody. Thank you for being here, and thank you for showing interest to all the stakes that are very important for Canadians who suffer from rare diseases. We can all be proud to see that the National Strategy for Drugs for Rare Diseases helps now patients, Canadian patients, in particular those who are treated by the drugs included on the common list. However, as we said several times before, this strategy isn't just about drugs. It also works on an important funding in order to improve the diagnosis and the screening. And today, we haven't seen enough measures targeting these strategies and access to drugs. These are key elements to help families who have to face lots of challenges even before getting or reaching a treatment. A recent survey of the Canadian Organization for Rare Disorders, who was carried out by Ipsos, explains that patients have to go through several doctors in order to have diagnosis, and this has repercussions on families and the community, but also on the health system. At ACORD, we are determined to improve the diagnosis everywhere in Canada, and this will be the strategy and also our priority on national strategy. We are also eager to plan the next phase of this strategy beyond 2027, making sure that the federal government keeps on guaranteeing direct funding and durable funding for drugs and creating care models that would be more comprehensive in order to change the situation for patients and their families. In my daily work with affected families by Loeys-Dietz SLD, which is a genetic disease that is rare and that affects many aspects of their lives, I always hear the same stories. Parents are exhausted because they look for an answer for many years. Young people navigate through systems, through different specialties, and patients have to leave their provinces in order to have a vital assessment. So these challenges could be avoided because when families, diagnosed at an early stage, when they have access to a systematic screening, we can prevent catastrophes, save lives, and enable kids who suffer from these rare diseases such as SLDs to have a better life and have an active life. We must do more for these patients and their families, as well as for all the Canadians who suffer from rare diseases. It is not a 3-year project only. It has to be an important element of our healthcare for many years. And this is in the interest of all Canadians. My name is Jida Al-Hajar, and I am the CEO of ACORD. Thank you.
I am Jennifer Adams, a family physician in Ottawa and an advocate for Primary Hyperoxaluria Canada. My family's journey has been profoundly affected by access to a rare disease drug on the common list of the National Strategy for Drugs for Rare Diseases. After 18 months of multiple tests, visits with specialists, dismissed by a system that I worked in every day, my daughter was diagnosed with primary hyperoxaluria type 1, PH1, a rare and life-threatening genetic condition. It felt like we were handed a rickety raft and told to cross the ocean. Without treatment, our daughter faced a terrifying future of excruciating kidney stones, irreversible kidney damage, and the looming need for dialysis and kidney and liver transplants, or even death. We were trapped in a state of fear. Our rickety raft would capsize with her next infection. Her next blood work would reveal a gaping hole we couldn't repair. As parents, we felt helpless. We were lost in the dark, treacherous waters of life with a child with a rare disease. Then came lumasiran, Oxlumo. This life-changing medication became our lifeboat, offering safe passage. My daughter's quality of life improved, reduced hospital visits, and no doubt has delayed and more likely eliminated the need for costly dialysis or transplants in the future. My husband was able to return to work, and we began to live a normal life. It's a journey only available to a fortunate 5% of rare disease patients, as 95% of rare diseases have no effective treatment. We are eternally grateful this miracle drug exists. The National Strategy for Drugs for Rare Diseases is our lighthouse. With a list price between $100,000 to $200,000 per dose every 3 months, lumasiran is a passage most cannot afford. The strategy's light keeps us from crashing into despair, allowing us to stay afloat. But the supply is limited, $1.5 billion over 3 years. Funding meant to keep this lighthouse shining. And while it may be tempting, even well-intentioned, to share that limited supply beyond its purpose, there's much to get done, much that was promised. Without it, families are left to drown. Our daughter and all rare disease patients deserve a reliable, sturdy lifeboat, and we need a lighthouse to guide the way to hope and safety. Keep the light burning. Thank you.
Thank you to the three of you for sharing your points of view with us this morning. Ordinarily, I would turn to questions in the room, but I see none from my colleagues, nor do we have anybody online. So I will take my privilege to ask a couple of questions, if I might. First, just a factual one. I wonder over the lifespan of the strategy right now, if you can say how many people have been helped and received the access to the care they needed because specifically of this strategy. Do you know?
I don't think we have an exact number. We are waiting for the provinces to report back on the first year of the
As always,
funding.
yeah.
What we do know is that there are 9 rare diseases, drugs that have been included, including Oxlumo, as Jennifer talked about. We know that these are available, not all 9 of them, across all the provinces, but definitely hundreds of patients have been able to get access, and there are quite frankly hundreds more that could be eligible, but some have not been diagnosed, some have not yet been prescribed for care. So we'll wait and see what the exact numbers are that are coming out. Not all $1.5 billion is going to these 9 drugs. There is much more of the monies that can be used for diagnosis and screening. And also a good portion, maybe 40% of the monies, is allocated toward what they call either leveling the care that's already, treatments already available across provinces, because we don't have a uniform, access, but also for new and emerging drugs, which of course continue to be made available. So I don't know an exact number, but we do know there are literally hundreds of patients that have been able to benefit.
Maybe just to pick up on that, the new and emerging drugs. I think it's been, reported and discussed a lot in this country about how long it takes for drug approvals here, and the question of, there's 2 elements of that. I'd welcome your thoughts on. One, there used to be a time when people would say, why can't we just, if it's approved in America, why can't we just use it here? But now, with what's happening with American politics and healthcare, I'd welcome your thoughts on whether that's still a realistic way to approach drug approvals in Canada, to trust American data.
I don't think the data are necessarily different, because one of the big advances we've been able to make in the U.S. and elsewhere in Europe as well is that we can accept global data. And for rare diseases, you almost have to have it because the numbers are so small. The value of having Canadian data is the fact that clinicians have been involved in clinical trials, so they have experience with the drug. So when it comes available to be used, we've got a network of clinicians who know how the drug works. The patients are already on it. So for us, getting clinical trials in Canada is hugely important, not just for the data, but because we want to have the experience. And of course, it's early access. I think as Jennifer indicated, it's the only drug. And so for a patient to get into a clinical trial, that is absolutely a miracle in and of itself. And what we have experienced and what we are really excited about is that Health Canada actually does approve in a very timely fashion. Once upon a time, we would have to kind of wait much longer. So Canada does have an accelerated process for what they would call, life-threatening rare disease drugs. They have a pathway that is faster. I think we also have a lot of mutual kind of recognition sharing of the data. They're able to take a data file from the US, bring it into Canada, fold it into their regulatory process, which we think actually is much more safe. And so as long as they're timely, as long as they can do it to the same standards, I think it really is a benefit to have Canada having had the regulatory expertise, because many of the drugs also require ongoing monitoring and follow-up. So now they understand what they're looking for. And sometimes their approvals are not exactly the same as what the US has, not exactly the same as what Europe has, in part because we also have a different system. So our goal is for Canada to work as quickly and as well as any other countries. For some ultra rare conditions, I think we do say, okay, we can accept the data file. But I think Canada, I give them a lot of credit, has really moved up to be able to do as much as possible to be able to share data and contribute also outward. So we have a few drugs that actually come to Canada first. And so then we've got a data set that can also be shared.
And then just to pick up on this theme, and this will be my last question, just reflecting back then on what happened in British Columbia in the summer with the little girl, I believe her name was Charlie. And there it was Canadian medical experts saying, no, this drug is no longer applicable in this situation. And the government went and got advice and took it from elsewhere. So how do you navigate that?
So we were very much involved in the situation. And so let me kind of make it a little bit clearer in terms of what actually happened, right? There are criteria for the drug being made available. There were at the time, some 7 or 8 years ago, some criteria for what the patient would need to continue to demonstrate in terms of responses to be able to continue on the drug. But the requirement was made at the time the drug was approved that we would do ongoing real-world collection of information to be able to demonstrate that the drug actually still works and that the criteria is the same. So to be absolutely accurate, there were, when this came back to the drug agency, Canadian Drug Agency, to reassess. So there was a request made. She was being taken off the drug. Quite frankly, her clinicians and the other experts in Canada said she should stay on the drug. It was not the doctors that were experts in that drug that were saying she should be taken off the drug. And they actually made the application back to the Canadian Drug Agency to say, here are studies, can you review them? They submitted 9 studies. 8 of them, even though they were published studies, the Canadian Drug Agency rejected because they didn't like the study design. They didn't see that there was a placebo. They didn't feel like some of the measures being used. We made the argument that what they were using as standards for post-market real-world studies was not appropriate, especially for a rare disease drug. I cannot do placebo drugs. I cannot do that kind of comparison that you want. And certainly the experts in the disease in Canada were all saying Charlie should remain on the drugs. The doctors that said no were the doctors that were advisors to BC's agency, and I know some of them, and they're great doctors, but they were not experts in this disease. They were using criteria that was very much grounded in terms of what the process was, so they were much more process-oriented as opposed to actual evidence-oriented. And I don't think it's their fault. I think we do not have a system that actually reviews rare disease drugs, continues to evaluate it to the standards that the rare disease drugs need. We have long advocated for the need for having a unique pathway for rare disease drugs. Many, many countries have this. Same data set, the same timing in terms of Charlie's case with this disease. in England, NHS. They're evaluating 5 years of post-market data, and they will come back with a determination for this same drug and for these same diseases. So the failing was not Charlie. The failing is the system, and the doctors who rejected it are great doctors, but they're not experts. The experts say yes, stay on the drug.
Thank you very much for your time here this morning.